Cindy, Alex, it's really, really a great honor for me to be here. As mentioned, Tom and I shared patients for many years together, and you know, you always, right now I'm working really hard at trying to recruit a couple cardiac surgeons, and for many of the people in the room, you know that if you want to find a great cardiac surgeon, you go to the scrub nurse and the perfusionist. And the same thing with the oncology community. I mean, my nurse practitioners just absolutely adored Tom, and you know, said, boy, I wish I could be treated by a doctor like that. And I think one of the unique aspects of how he approached cancer care in general was his unique dedication to the patient of today, but also his dedication to the patient of tomorrow. I mean, the importance of innovation, discovery, clinical trials, and moving the field forward, as well as the neutropenia or other complication that patient may have right away. And this is just one example of Tom's contribution to the pancreatic cancer field. The phase 3 randomized trial of Gem-Nav versus gemcitabine alone, published in the New England Journal of Medicine. And one of the aspects of that, of the results of that trial that I chose to just show here is the fact that look at the partial response rate. And again, I'm a surgical oncologist, so that means I'm kind of like a closet medical oncologist. I probably say a lot of stuff, but I usually can get away with it because the medical oncologist in the room will say, he doesn't know what he's talking about anyway, but no one really gets too worked up. But you can see the partial response rate of about 23%, and that kind of is something that we've been interested in for many years, is why can you have a situation like this? So this was probably one of the first patients I operated on after Gem-Nav, and this was her CT scan at the beginning, and I can get my, I'm going to use the little mouse here, I think. I'm going to try to use the mouse. And you can see this tumor adjacent to the celiac axis with my arrow. Just a huge tumor, and the image below is just one cut below. And look at what happened in response to this therapy. So just fascinating. In her particular case, without going through all the anatomy, we ended up taking this out. And I think the future of certainly the surgical management of pancreas cancer is going to be exceedingly complicated, because more and more patients will still be standing after responses to systemic therapy, which we haven't seen in the past. And in this case, we ended up taking out her tumor with her celiac artery that you can see there. Fascinating. I'm going to talk about this in a minute. Look at this. Actually, node-negative disease after induction therapy. If you operate on patients straight away for pancreas cancer, the incidence of node-negative disease is probably around 25%. And then in this particular case, we put her celiac artery back together with a piece of vein from her leg. In contrast is a woman who lives 2 blocks from me in Whitefish Bay, Wisconsin, which is a little, unfortunately, a little strip of southeastern Wisconsin with the highest incidence of pancreas cancer in the United States, actually. And right now in Wisconsin, pancreas cancer is the second leading cause of adult cancer death. She had absolutely no response to gemcitabine and nab-paclitaxel, had a much smaller tumor, was actually treated on a clinical trial. We took her tumor out, had to remove a segment of her SMV portal vein. Her splenic vein was plugged into her left renal vein. This area looks beautiful here, looks absolutely beautiful. However, 6 months later, her tumor had recurred. So why would we have such a great response in one patient and no response in another? And that is the focus of what we're trying to sort out with this disease. Well, if you are diagnosed with localized pancreas cancer in most places in the United States, this is how you would be treated. Your disease would be diagnosed and staged, and we've certainly made tremendous progress in staging over the last decade. And then if the tumor is localized to the pancreas and thought to be removable by the physician team, you would be brought to the operating room. Typically, if everything goes well, your recovery period would be a couple months. And then before receiving adjuvant therapy, you would once again be restaged, CT scan, etc., and then receive adjuvant therapy. What we don't know is the biologic impact of this treatment strategy. We certainly know that surgery is an immune suppressive event. And many of you have had patients who have undergone a big operation, and it just seems to irritate any microscopic disease that might be around elsewhere. Unlike other solid tumors where the operation may be more modest in magnitude, this is usually a big operation, anywhere from 4 to 8, 9 hours in the operating room, and 7 to 10 days in the hospital, typically 6 weeks recovering, during which any micrometastatic disease obviously would have a biologic advantage, correct? What we do know, however, is that there's been no progress in decades. This is a recent paper from Memorial Hospital in New York, where you can see they looked at Whipple patients who may or may not have received adjuvant therapy and looked at their survival curves, and absolutely no difference by decade. Just amazing when you think about it. And if you extrapolate the median survival here, you know, it is right at about 2 months, and just keep that, I mean, at about 2 years. Kind of keep that 2-year median survival in the back of your mind a little bit. Here's the experience from Hopkins. And whether or not you had a complication, didn't have a complication, received adjuvant therapy, didn't receive adjuvant therapy, once again, it's fascinating. Median survival, even in the best survival curves, of about 2 years if the patients are brought straight to the operating room. And this is a paper from Rich Swanson, who was in the fellowship in Houston a year ahead of me, where he looked at 90-day mortality with pancreatic surgery in the United States. And as you would expect, the mortality rate was varied based on the experience, or if you will, practice of the surgeon in the hospital. Higher volume institutions tended to do better. But you can see that overall in the United States, this is not an operation that is straightforward. Certainly, the mortality is significant. I wanted to give one little shout out to a surgeon who will be coming to Northside soon, Eddie Abdallah, who was a fellow with me in Houston. And Eddie and I did this operation on this patient, who's a fairly well-known patient in internet circles. This is Mary Sharkey, who was a huge advocate for pancreatic cancer awareness that Eddie and I operated on now probably 15 years ago with NBC in the room, because she was highlighted in a kind of a docudrama, Houston Medical, replaced the hepatic artery, patched the portal vein, and he certainly will bring a tremendous level of expertise to this institution. This is a paper from another one of my former fellows, Steve Leach and company, when Steve was at Hopkins. This was one of a number of papers in Cell in 2012 that suggested that pancreatic cancer is a systemic disease at the time of diagnosis in almost all patients. And I already mentioned this. It's pancreas cancer is already #2 cause of adult cancer mortality in Wisconsin, soon to be #2 throughout the United States. Well, I got involved in this actually when I was a fellow, and in order to graduate from our fellowship program to get a certificate, you had to write a clinical trial. And I was sitting there in a conference one day saying, my goodness, they're giving radiation and chemotherapy for rectal cancer prior to surgery. I think at that time, chemotherapy was also coming into the clinical management of breast cancer prior to local therapy for breast cancer. And I just said, I'm no expert here, but I'd rather have breast or rectal cancer than pancreas cancer. Why don't we give something first for pancreas cancer? And the clinical observation was really in advocacy of that patient who came back 6, 9, 12 months after surgery and already had recurred. We said, is there not a way to find those patients who are destined to be early failures and avoid the operating room? Because my goodness, it certainly does not benefit them. This is a paper, this is a slide that one of my partners, Susan Seay, put together, and I think it's particularly relevant here because it was published from an Atlanta group. Volkan Adsey is a really talented pathologist at Emory, and he published this paper recently looking at the patients from Emory and from Wayne State, where he used to come, where he used to work, who were operated on first and then may or may not have received adjuvant therapy for pancreas cancer. And you can see that those patients who were node negative had a median survival approaching 3 years. And then Susan compared that to our database at the Medical College of Wisconsin, a fairly robust number of patients for surgically managed pancreas cancer at both institutions. But look at the difference in the node negative rate. In those patients operated on first, about 1/4 of patients were found to be node negative. In those patients operated on after induction therapy, about 2/3 of patients were node negative. Clearly there is a stage migration that effectively occurs with neoadjuvant therapy, and the survival in those patients who are converted from node positive to node negative is, if anything, better than the node negative patients who are operated on first. Treatment sequencing, irrespective of the therapy, clearly may have a major impact in this disease. Well, when I was in Houston, we did a variety of trials, and this was basically, we copied this after the NSABP. We took what we thought was good about one trial, moved it into the next trial, took the things that we didn't think worked and tried to move them to the side. All of this has been published, but I wanted to just show you in kind of thematic form why this seems to be logical for this disease. So this is the first gemcitabine with radiation trial that we did. So patients are staged. They are then given neoadjuvant therapy, and remember this is all eligible patients. Then given neoadjuvant therapy, they're then restaged and brought to the operating room. The theory being that patients who are not sensitive to induction therapy, who have, if you will, radiographically occult micrometastatic disease at time A, may actually have that metastatic disease appreciated after induction therapy to which they may not be sensitive, and they would therefore avoid a big operation which would provide no therapeutic benefit. Again, advocating for the patients who have aggressive disease. This paper was published once we had a minimum survival of 5 years, a minimum follow-up of 5 years on all surviving patients. 86 patients, consecutive patients enrolled. 22 patients did not undergo successful surgery because they had disease progression at restaging or at laparoscopy, and you can see that the median survival of those patients was relatively short. Surgery in those patients would have clearly provided no therapeutic benefit. Importantly, this strategy of something given prior to surgery effectively dichotomized the population into those who would benefit from a big operation and those who would not. Importantly, looking at all patients, their survival was equal to those patients who had surgery first. And those patients reported who had surgery first in the Hopkins and Memorial trials I showed you, they didn't include the patients taken to the operating room who were found to have locally advanced or metastatic disease at surgery. So they even selected out a better performing group. And the median survival of those who completed all therapy to include induction therapy plus surgery was almost 3 years, something really never reported previously for this disease. This is a recent look at our database at MCW and comparing those patients who had surgery first. Again, if you look at their median survival, it's unbelievable how reproducible that number is. It just has gone nowhere in decades. Operate on someone with pancreas cancer, with or without adjuvant therapy, you just don't seem to be able to move off of that 2-year median survival. Clearly, neoadjuvant therapy plus surgery effectively dichotomized the population into those patients in whom a large operation would appear to be worthwhile, and in those where avoiding surgery clearly important. In a paper we recently published looking just at resectable patients, median survival was even much longer, almost achieving a 4-year median survival. This is now in the more contemporary era of gemcitabine doublets, FOLFIRINOX, etc. Interestingly, when we looked at just those patients who had an elevated CA 19-9 level at diagnosis, now About 20% of patients, due to the Lewis blood group antigen, will not have an elevation in this common tumor marker that we use. But those patients who were elevated, and then we gave them induction therapy of some kind, and once again looked at their 19.9, you can see the survival of those where the 19.9 normalized, came down but didn't normalize, and actually increased. A great lesson here. If you have a patient who's a little bit complicated, maybe a little older, medical comorbidities, will need a difficult operation, that 19.9 is not normalized in response to induction therapy, surgery may want to be reconsidered. So right now, certainly in the era of immune checkpoint blockade, the impact of the host on the tumor treatment relationship is a huge area. This is now slowly making its way into pancreas cancer, although, as everyone knows, immune checkpoint blockade alone in pancreas cancer is not effective. But what I'm going to spend my last few minutes on is just a simple clinical trial, and talking to mostly medical oncologists, I'm almost a little embarrassed because this is kind of like personalized medicine 101, but the important point is it created the infrastructure for the next generation of more complicated studies. Pancreas cancer patients are difficult because you have a stent in the bile duct, you may have pain that is difficult to manage, they're older in age, you may have a problem with gastric outlet, nutritional management, etc. They are a multi-system, complex situation. What we have done for years, beginning in Houston and now in Milwaukee, is we separate diagnosis and treatment. So frequently, you see this as a continuum in this disease. A patient gets yellow, they get a CT scan, they have a mass in the pancreas obstructing the bile duct, and they may then go to the operating room. Well, if you think about it, we don't treat any other disease in endocrine surgery, in solid tumor oncology like that. We diagnose the disease and then we stage it. So probably for the last 15 years we have done this. The other advantage of this is patients can enter anywhere into the system. They can enter through gastroenterology, medical oncology, radiation oncology, primary care, and everyone knows we treat pancreas cancer the same way we treat gastric cancer, rectal cancer. We stage the disease. So they get staged with an EUS. If they are yellow, they get a stent in their bile duct. They have cross-sectional imaging done first, and they're then presented at our multidisciplinary conference. And the treatment we're using is right now is to try to determine, can we find patients who are more likely to be sensitive to one combination of therapy compared to another. Remember that you can, as I showed you at the very beginning, we had that woman who actually was from Atlanta who had that phenomenal response to Gem-Nab, and then my neighbor 2 blocks down from me who didn't respond at all. Can we not sort that out? So this is what we looked at, and again, you'd say, boy, this is like, you know, personalized medicine 101. But this was what we looked at are these molecular profiles based upon the FNA biopsy obtained at the time of endoscopic ultrasound. So SPARC thymidylate synthase, gemcitabine associated genes, platinum and irinotecan. And many of you in this room know a lot more than this about this than me, but obviously high SPARC, benefit from Gem-Nab, Topo1 benefit from irinotecan, the 2 gemcitabine-based genes, ERCC1 for platinum, thymidylate synthase for fluoropyrimidines, based on the FNA biopsy obtained at the time of EUS. And then we created an algorithm based upon the expression of these by immunocytochemistry. And we've now enrolled about 120 patients in this trial. Our next trial will bring a much greater level of sophistication, which will open in about 2 months. But importantly, by doing this basic, simple trial, we have created the foundation with endoscopy, pathology, medical and radiation oncology and surgery to do more sophisticated studies in the neoadjuvant setting when the patient may have a biliary stent and associated other complexities. And you can see we obviously, if you take GEM for example, we prioritize SPARC over ERCC1 and so forth. Just to give you a couple examples, in this patient, based upon their FNA profiling, they profile to either 5FU or GEM. So Spark expression was negative, ERCC1 was negative, placing them into the FOLFIRINOX category. This patient got FOLFIRINOX. Same exact logic in this patient, where they profiled for 5FU against GEM. ERCC1 was overexpressed, suggesting lack of benefit, and therefore they went down to Spark, and Spark suggested that NAB paclitaxel would be effective, and therefore they received a regimen that one would not normally give as first line for this disease, again on trial. This patient received FOLFIRI, and you'll say, well, my goodness, I wouldn't use that for pancreas cancer. This is that patient's initial diagnostic CT scan, right here, large tumor mass in the pancreatic head, hot on PET, after 4 cycles of FOLFIRI, clearly an effective systemic therapy in this patient. Again, this is actually based on the original Bisgrove trial that Dan von Hoff did in metastatic disease. We were effective in profiling about 75% of the FNA specimens. 25% of the specimens did not have adequate tissue. Many of these patients were biopsied prior to referral and already had a metal stent in place, which made it difficult to rebiopsy them. Importantly, patients have been treated throughout the United States. The only requirement for this trial was initial staging at our institution, and then this trial required surgery at our institution, but the chemotherapy, radiation therapy could actually be given anywhere. So we've had patients from Texas, Louisiana, Atlanta, Alaska, etc. And it's been really fascinating managing these patients long distance and interacting with all the medical oncologists that have been involved. The patient gets an operation, the tumor is then reprofiled, and the therapy is then directed on the back end or adjuvant for another 4 months. When we compared the patients who had been treated historically at the Medical College of Wisconsin with neoadjuvant therapy, in other words, what we thought was the best appropriate therapy, and compared them to this trial, and we used as an endpoint completion of treatment. And the theory there is that if you assume everyone has metastatic disease at the time of diagnosis, if your treatment is optimal for that patient, the micrometastatic disease will not be apparent at the time of restaging. Hopefully it will be effectively treated. And if you believe the basic science data that most patients have metastatic disease at diagnosis, those patients who are long-term survivors, the 20 to 30% of patients who are long-term survivors, do probably have effectively treated micrometastatic disease. But in any event, a surrogate marker of outcome, at least early outcome, would be a normal restaging and a successful operation. If you compare our historical numbers of resectable and borderline resectable patients, 80% of patients with resectable disease complete all intended therapy to include surgery. 55% of patients with borderline resectable disease. Those patients on the clinical trial, 93, and these are just patients who have adequate follow-up, 93% of patients with resectable disease, 77% of those with borderline resectable disease. So at least a signal that maybe there is something to this. If we then compare those patients who were treated on trial where the target was identified, in other words, the molecular profiling was successful, and the patient received profile-directed therapy, compare those patients to the 25% of patients entered on trial where the FNA biopsy did not have adequate cells. They were therefore not successfully profiled, and they received what we thought was best available therapy. So for example, FOLFIRINOX followed by chemoradiation followed by surgery. Again, those patients who had successful profiling, 90% of patients completed all intended therapy to include surgery, compared to the 71% of patients who did not have adequate profiling. So again, using an internal control in the trial, again suggesting that there may actually be something to this. Importantly, we have serial blood and tissue acquisition on all patients beginning from the time of diagnosis. We're looking at a variety of different biomarkers. I think probably within 3 to 4 years with pancreas cancer, we will be at a place using a variety of biomarkers, cell-free DNA, circulating tumor cells, in addition to tumor markers. We will be in a place where you will be able to very accurately prognosticate whether the operation will be of clinical benefit to that patient who's sitting across from you in the clinic. And again, this is because this is a big operation. One of the things I noticed when I went from a cancer center to a general hospital that I really struggled with, and I probably still struggle with it today since I'm telling you the story now, is that at the cancer center there was never an A given for effort. If the patient died or the cancer came back within a year or within 2 years of a Whipple operation, for example, then they shouldn't have had the operation. It didn't matter that the doctors tried. It certainly was expected that everyone tried, but that didn't matter. It was, what lesson can we get from this? And I think that now that I'm at a general hospital where we have exactly opposite diseases to aggressive solid tumors like pancreas and liver, if you take something like liver transplantation, right? If the patient gets successfully transplanted, they'll have an 80% chance of long-term survivorship because you don't have a disease-related mortality. Whereas with pancreas cancer, you have a significant disease-related mortality. So I think an operation that imparts a defined risk of perioperative death and an obvious recovery period of 2 to 3 months, if that patient is going to recur within 18, 24 months of surgery, it's incumbent upon all of us to find how can we find those patients and avoid an operation in those patients. Well, it certainly takes a village to take care of this disease, and this is our village in Milwaukee. And I know that Patty and a variety of others met some of the clowns, including me, that are on this slide. And the last bit of philosophy I'll leave you with is patients will become increasingly complicated with the improvements made in systemic therapy. In other words, they'll still be standing. So right now we actually have this is a patient I took care of from the University of Iowa who required a huge operation, and he was sent to us as one of the first patients in the category that my nurse practitioners classify as now still standing. In other words, still alive, but shouldn't be. So had about a year of therapy, or 9 months of therapy, and what do you do with that patient? We have a little pancreas symposium every winter for mostly for the medical oncologists in southeastern Wisconsin, and we invite a medical oncologist from around the country every year. Last year we had Brian Wolpin from Dana-Farber, and one of the short little excerpts that we presented was our patients who had these mega operations. You can see where we replaced the portal vein, replaced the hepatic artery, and these patients all received an operation after a lengthy period of induction therapy. And when we said, okay, Dr. Wolpin, what do you think? And he said, you know, I'm really not that impressed. I mean, how do you know that surgery did anything? A great lesson, but it's almost impossible for all of you in this room, if you have a patient who, after 9, 10 months of therapy for, say, pancreas cancer, and they're clinically well, and the only abnormality is on the CT scan, it's almost impossible not to address the abnormality on the CT scan, right? Almost impossible. Hopefully, with time, we'll be able to determine in which patients doing a big operation like this helps and in which patients it doesn't help. I think one of the unique things, and I'll close with this, about Tom, as mentioned by many people who talked about him already, was that he created a village around him. And maybe I didn't know Alex was going to tell this story earlier, but at least to me, he made the complicated appear understandable, but I was referring mostly to group dynamics, interpersonal relationships, and team building, where I think he had a unique ability. And certainly I think John Kerry and a few others in our government could take a huge lesson from him. Anyway, thank you all very much for